Hello, everyone. Just hang tight for just a few more seconds. We're going to allow some of the people that are attending to join. We'll just wait for that little wheel to quit spinning. So just hold tight. Thank you in advance. Thank you all in advance for holding. We're just waiting a few more seconds where there are some people that are going to be joining us. We know it takes a while for the connection to go through. So hang tight for about another 10 seconds and we'll start the webinar. Hello, everyone, and thank you for joining us today. I'm Andrea Jensen. I'm the education specialist for Allergy and Asthma Network, and I am a certified asthma educator. All participants will be on mute for the webinar. We will be recording today's webinar, and we will post that on our website within a few days. You can find all of our recorded webinars at allergyasthmanetwork.org. Scroll down to the bottom of the page, and you will find all of our upcoming webinars and any that have already been recorded. The webinar will be 1 hour, and that will include time for questions. We will take those questions at the end of the webinar, but you can put those in the Q&A tab at any time. That's on the bottom of your screen on the left side. Please put them in the Q&A. Sometimes they're missed if they're in the chat because the chat can get quite lengthy. We'll get to as many questions as we can at the end of the webinar. We do not offer CEUs for this particular webinar. However, you can get a certificate of attendance, and we will put the link to that in the chat. You will receive an email a few days after the webinar that will have a link to be able to review this webinar, share it with anyone that you wish. We'll also have a link to the certificate as well as any other resources about long COVID. So long COVID impacts millions of Americans, about 60 million Americans. Are you one of those with long COVID and lung problems? I know that I am. Today, we'll learn more about research and treatments. Allergy and Asthma Network is a grassroots organization that was started over 35 years ago by a mom who knew that other moms like her needed resources and support. Our mission is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and we also do research. Today, it's my pleasure to introduce our speakers, Dr. Lekshmi Santhosh and Dr. Shari Brosnahan. I'll read Dr. Santhosh's bio first. She is an associate professor of medicine in the divisions of pulmonary and critical care medicine and hospital medicine. Clinically, she attends the medical ICU, the neuro ICU, on the internal medicine teaching wards, and has clinic at the pulmonary outpatient faculty practice at UCSF Parnassus. She is the founder and medical director of the multidisciplinary long COVID post ICU optimal clinic at UCSF Health. Her education and research, she serves as the associate program director for curriculum for the internal medicine residency and the associate program director of pulmonology and critical care medicine fellowship. She is also the director of the Department of Medicine Grand Rounds. She obtained her master's in health professions education from UC Berkeley. Her primary scholarly interests in medical education research are related to ICU transitions of care, women in leadership, clinical reasoning, and subspecialty career choices. And now for Dr. Shari Brosnahan's info. She's an attending pulmonary and critical care physician at NYU Langone Health in New York City. She received her medical degree from University of Texas Health Science Center in San Antonio and completed her internal medicine residency at Temple. Completed pulmonary and critical care fellowship at NYU, where she was the chief fellow and joined the faculty in 2017. She holds a master's of science in clinical investigations from NYU and is an assistant program director for the fellowship program. Her research interests include acute and chronic pulmonary embolism, COVID, you can say that term for me. Long COVID brain, I apologize. And
coagulopathy.
There you go. Thank you. And ICU outcomes. At this time, go ahead and take it away. And thank you so much for taking time out of your busy schedules and out of the ICU to help people across the US understand a little bit more about long COVID.
Thank you so much for the kind introduction and the invitation to speak. Here are conflicts of interest disclosures for your information. And so just to set the stage, I remember, and I still have this paper copy of the New York Times, where it says, US deaths near 100,000, an incalculable loss. And here we are, after having millions of people who have COVID, and now a subset of those patients with long COVID. I always tell people that COVID is down, but it's not out. And this is particularly relevant when it comes to long COVID. You see here the New York Times tracker, and they actually stopped updating it regularly starting in March 2023. So even our data about current COVID estimates and long COVID estimates has become more difficult to ascertain. There are people still in the news, like my own Department of Medicine chair, Dr. Wachter, who still are trying to spread the public health message that we should still try to avoid COVID. And he says in this article, quote, "There's still a fair amount of COVID around, and I still don't want to get it. The main reason is the data we see on long COVID is very concerning. Not just the chance that you're going to feel crummy a few months from now, which is a real number, but also the chances that you're elevating your long-term risk of a heart attack or stroke or diabetes or more." So these are serious considerations when we're talking about public health messaging about COVID and long COVID. So how are we going to spend this hour together? First, we're going to talk about defining long COVID with a particular focus on the pulmonary symptoms as two pulmonologists. We're also going to talk about the why. What are the current understanding of biological mechanisms? And we're also going to talk about who's at risk and how so. We're going to talk about pulmonary conditions that increase long COVID risk or how they intersect with long COVID risk. So diving in, I think early in the pandemic, back in March 2020, investigators, clinicians, researchers all found out that COVID can affect multiple organ systems acutely, not just the lungs, our favorite organ, but also the heart, the brain, the immune system, even the reproductive system. And so it's no surprise that COVID also affects multiple organ systems long-term. Everything from, again, long-term lung scarring, long-term heart impacts, mental health and brain impacts, as well as neuromuscular impacts. And a subset of these patients we found out fairly early on actually have this different kind of condition where there's kind of a waxing and waning symptomatology, where symptoms kind of come and go, they can flare up. There's a lot of fatigue, particularly post-exertionally. And there's paresthesias, tingling, cognitive impairment, brain fog, dyspnea, shortness of breath, and palpitations. And the CDC, with latest research, has found out, and they estimate that about 1 in 5 adults actually have a health condition that might be related to a previous COVID illness, again, across the whole body. And we're learning more about this as the research progresses. This is just 2 examples of studies that have come out in the last couple of years, which show that, again, there's multiple organ systems with multiple symptoms involved that comprise long COVID, which is, first and foremost, an amazing patient community generated term. I just wanted to call that out specifically, that this is a patient community generated term that we are using to, again, be patient-centered and align with the patient community. The other thing that we commonly combat the misinformation or stereotype about is that it's just like the flu. And actually, this study is no longer in press. Sorry, it was published last month. And this study by Dr. Al-Ali and colleagues showed that even compared to influenza, COVID has much more significant impacts, again, in multiple organ systems. So let's focus for the rest of this talk on the pulmonary symptoms, which is our charge today. Even before we knew a lot about COVID, we know that when people were very sick in the ICU for a lot of different pulmonary problems with acute respiratory distress syndrome or ARDS, pardon me, recovering from a daycare plague from my toddler. And so we knew that people with ARDS, respiratory symptoms, severe respiratory failure, could have functional disability, could have pulmonary function tests that were abnormal for years after initial study. This is a great slide that I love from my counterpart who runs the long COVID clinic at UCLA, Dr. Kristen Schwab. And she points out, and I show this graphic to patients all the time, that when patients deal with persistent shortness of breath after COVID, there's a lot on the differential. Common things being common, one of the things that we commonly see is that people who didn't have asthma or COPD might actually have a new, what we call unmasking, where after a viral infection like COVID or RSV or influenza, they get sort of a new diagnosis of asthma or COPD or other obstructive lung disease. Sometimes that could be a new diagnosis. Sometimes it could also be a worsening of baseline lung disease. And Dr. Brosnahan is going to talk about that a little bit more. So oftentimes I see patients with mild asthma, they get COVID, then they come to me and now they have moderate asthma, or moderate asthma, now they're kind of in the severe category. We'll talk about that. So that's one of the most common reasons for shortness of breath after COVID. The second one, which is really big too, is deconditioning. And I don't mean that to say that all shortness of breath is deconditioning. There's multiple mechanisms. These are just 5 of the most common mechanisms at play. Deconditioning is that when our muscle strength goes, the muscles supporting our muscles of respiration, our breathing muscles, also get significantly impacted. One of the third things that we see is called organizing pneumonia, which is a very specific subset. It's a special type of kind of interstitial lung disease that's often responsive to steroids that we see with a classic CT scan finding. So that's rare, but some studies show that about in the 1% to 2%. For people who are in the ICU with severe COVID, post-ARDS or post-severe respiratory lung fibrosis is another big thing that we can see. And people can recover from that or even plateau at different levels. And Dr. Brosnahan is going to go over that as well. And then last, we're learning a lot more about the role of pulmonary vascular disease. So we learned early on that many people with COVID have high hypercoagulability. They tend to get blood clots, especially in the acute setting. And we're still learning a lot about when does that risk go down? What is the risk of blood clots in the more long term? There's a lot of intriguing research about that, about microclots and things like that. But the big, acute blood clot, DVT or pulmonary embolism, PE, after COVID, we know it's highest risk in the early days. And we're learning more about what is the risk after the early days. Other things to consider are also classic causes that are non-COVID related, such as reflux often gives a cough, neuromuscular disease or vocal cord issues, or tracheal stenosis or tracheomalacia, particularly in people who've had a prolonged intubation from COVID. So when you come and see a pulmonary specialist with long COVID, we are not just reaching immediately for a treatment because we're trying to figure out what of these mechanisms is at play, or could there be multiple mechanisms at play? And speaking of mechanisms, why do people get long COVID? What's understood about that? This is a great article, again, led by the patient community. So the first author on this article is Hannah Davis, published in Nature Microbiome. This is a great review article that came out in 2023 that has a lot of great graphics, including this one. So this graphic kind of shows what are the current streams of scientific evidence about why long COVID exists. It's everything from immune dysregulation, perhaps from persistent infection, viral replication, reactivation, dysregulation of the gut microbiome, difficulties with autoimmunity and immune priming, blood clotting and endothelial abnormalities, like I just discussed, dysfunctional neurosignaling. So each of these 5 pillars actually has multiple different studies supporting these. And I think one of the challenging things that we're going to talk about throughout is that there is no one long COVID, because different people likely have different mechanisms at play. And so not everybody has all of these mechanisms. Some people might have a couple, which bears challenges for how we treat this complex, very heterogeneous condition. One of the studies, one of my co-investigators at UCSF is Dr. Michael Peluso, and his group and his team, the LINK study, which is closely linked with the NIH RECOVER study, has produced tons of articles with scientific insight into long COVID, including this one. This graphic here shows that specific elevated antibody levels is associated with people who have COVID-related shortness of breath and chest pain and palpitation. So we're learning more slowly but surely. And I know the progress is painstakingly slow, but we're learning more about what is the role of antibodies? What is the role of, inflammation? And how does that actually correlate with the symptoms that people are experiencing? We also have this new case definition that WHO came out with last year. And the definition is nice because it really encompasses a couple of key variables. They talk about history of probable or confirmed SARS-CoV-2. They talk about how you need to exclude an alternative diagnosis. They talk about the common symptoms of fatigue, shortness of breath, and that people can have waxing and waning or fluctuating symptoms. And we'll talk more about the latest definition that came out in a new JAMA trial. One key thing, a key point that I'd love to emphasize and emphasize again is that there is no one long COVID because each patient is unique. And there are some common symptom clusters that we'll discuss, but really each patient has really different symptoms. They probably have different underlying scientific mechanisms, and that a one broad, one size fits all treatment is unlikely to be helpful, and that we need to do more work to really figure out what is the underlying science, what treatments help specific patient symptoms and things like that. So we have a long way to go before we, continue to make progress on this, and that clinicians on the call listening in should make sure to try to think critically about, how is this patient unique? What are this patient's primary symptoms? How can I treat these primary symptoms? So let's dive into the latest trial that came out just this month, actually. And this was a trial from the NIH Recover study. And this was a really well done observational cohort study of nearly 10,000 patients that used very validated questionnaires like the PROMIS questionnaires to look at post-COVID conditions and disability. And what they did was they basically created a series of models that defined post-acute sequelae of COVID or PASC or long COVID. And what they did was they looked at these specific symptoms based on specific times, and then they came out with this essentially classifier looking at the most common symptoms, and then essentially assigned a scoring criteria to help capture those all together. This is just the first phase, they point out. They point out that this is currently used for research and not clinical practice. This is not a clinical score where you say, you get this score, you definitely have long COVID, but we're getting closer to being able to further define this. And as more imaging, pathology, and labs from this NIH Recover trial come through, we can probably integrate that information in this model, which is great. And so here's some pictures just showing the methodology of the different past symptoms that they looked at and the symptoms frequencies. And you see here that, for example, some of these symptoms like post-exertional malaise, which we talked about, fatigue after exertion, are extremely high. Almost 90% of participants in the study experienced that. Fatigue was another extremely common symptom. Brain fog, dizziness, GI symptoms, palpitations. So you see how this is a hugely impactful condition that really touches on multiple organ systems with symptoms. And again, here is where they looked at kind of the score to identify an optimal cutoff, an optimal threshold using this essentially summary score. These data really track what Dr. Fauci and many other clinicians have said, and many other patients have said for many years, which is that many people with long COVID have a post-viral syndrome with a lot of overlap with chronic fatigue syndrome or myalgic encephalomyelitis. And so these data really support that. They found that there are patients with, again, different symptom clusters. Many patients have a couple of symptoms that track together or cluster together. There was one group that seemed to be not that symptomatic. They had fewer symptoms. There was one group, a very dominant group, where they had a lot of chest pain, shortness of breath, and palpitations. There are other groups that have clusters with a lot of joint pain, headaches, muscle pain, things like that. There's patients with the prominence of the post-exertional malaise, fatigue, cognitive symptoms. And so many times when I talk about these findings with patients, this really resonates with people because they say, oh yeah, that's exactly me. These are exactly the kind of group of symptoms that I have. And so we're getting closer to kind of teasing apart what are the symptom clusters, what is the underlying biology, and then how can we treat that? Now I'm going to turn it over to Dr. Brosnahan to really talk about what comes next when different pulmonary conditions that people already have impact their long COVID risk. Turning it over to you, Dr. Brosnahan.
Thank you so much. And that was so well done. So we're going to go through the very common pulmonary comorbidities and talk to you guys about how that might affect your long COVID or affect someone's long COVID risk. Next slide. So first, we're going to talk about OSA. This was a study that was part of the Recover Initiative looking at EMRs as well. We took 3 different cohorts of EMR data and looked at patients who had had OSA prior to getting COVID and who did not have OSA prior to getting COVID. This was done in both adults and children. What we found was that there was a striking increase in the risk of long COVID in patients who had the comorbidity of OSA. Interestingly, that did not happen in children, only in adults. And as we controlled for other comorbidities, that went down. If you looked at the 3 cohorts that were used, the range of increase that OSA contributed was anywhere from 12 to 75%. And you might say, wow, that's a very pronounced difference. But what we found was in patients that were sicker, patients who had more comorbidities, OSA was almost additive to that. So patients who had more OSA, had more comorbidities, had more likelihood of long COVID. We also found that OSA was much more likely to be additive in women. This was perhaps possibly secondary to OSA tends to be found later in women and can be more severe because of that. And so there's not, this study is an EMR related study, does not give us pathophysiology, but hopefully will be the basis for us looking at various different mechanisms. We do know that sleep can be restorative. Next slide. Another common condition is asthma, and this is a meta-analysis from JAMA that basically took all different comorbidities, and this is looking at specifically asthmas related. There were 13 studies that were included in this meta-analysis of 640,000 patients. And if you can see, this is I'm not sure if people can see my pointer, but you can see the total effect size is 1.2, meaning the odds ratio is 1.2. That does not cross 1, meaning that there is an increased risk. And underneath that, you then see what's called a prediction interval. And that tells you how likely is this study is to be run again if the same result will be gotten. And so this shows that there's a very good fidelity between the studies, and that it does appear that asthma is clearly associated with long COVID in these patients. Next slide. But what happens, and we spoke about this a little bit earlier, what happens to asthma control after COVID? And this was a study out of the UK looking at about 4,500 patients. This is in the first wave. So patients have not been vaccinated. That is a caveat to this study, but it showed after someone had a COVID infection, what happened to their asthma control. You can see the top bar are people who identify as not having long COVID, and the bottom bar are people that are identified as having long COVID. And you can see that they say that their asthma control is significantly worse. Again, they say, and this is specifically about their asthma. On the right side, the right graph is talking about how their breathing is in general, not specifically about their asthma type symptoms. So did this impact their lungs or their dyspnea, or could it be a different mechanism like we were talking about? Did their underlying asthma promote them maybe getting a second physiology, causing a second dyspnea, not just like a RADS, like a reactive airway? And it appears that these people felt that their dyspnea was different than simply uncontrolled asthma in themselves, which is interesting that we might be at risk for getting another pathophysiology mechanism in this patient population. Next slide. COPD is a kind of an interesting story. It does seem like it is likely associated with long COVID, but the amount that we can predict whether these results are true or not is a little bit less. And there could be a lot of reasons for that. They're smaller studies. So this is an analysis in that same JAMA article looking at 10 studies, slightly fewer. Now we're at 250,000 patients, but still a lot of patients. And it did appear when they did the meta-analysis, excuse me, it's not in the study, that there was a total effect size. So you can see 1.38 that does not cross 1. But what is interesting is that the prediction interval does cross 1 just under there, meaning that there could be variability if we repeat these studies again, and there might be a negative study. There's some reasons why there were heterogeneity within the recruitment of the studies, but ultimately, one of the feelings of several authors in the study was that unfortunately, COPD was tied to death during COVID, and that will keep people from getting long COVID because they will have passed away. And so they felt like severe COPD patients who might, if they were able to survive and would have gotten long COVID, were kind of culled out of this cohort. So I think that there's still some confusion about whether COPD is truly linked to long COVID, but according to the meta-analysis, it seems likely associated. Next slide. So let's bring this back to a case. There's a 45-year-old female who has a past medical history of getting COVID in late 2020, who then developed symptoms of past or long COVID. And predominant symptoms were brain fog, shortness of breath, fatigue, exercise intolerance, and chronic cough. And I've highlighted the symptoms in this way because I kind of think of them slightly differently. We were talking about the pathophysiology of the different mechanisms. I put shortness of breath and chronic cough sort of together in my mind. And then I put fatigue and exercise intolerance together. And that guides kind of the beginning of my workup. Next slide. So if I think about working up for dyspnea, fatigue, and chronic cough, dyspnea, I often do an exercise evaluation and possibly a pulmonary function test in these patients. Fatigue, I will do a sleep evaluation, and we're not going to touch on sleep immediately in this talk because it could be just a whole hour in itself. But what I say is we have seen a lot of strange sleep-related disorders that have been appearing, including REM-related disorders, people having very vivid dreams, night terrors, acting out, restless leg syndromes, things like that, that can be linked to cognitive dysfunction in these patients, not simply hypersomnias or hypoventilation events, which we think of from OSA. So really getting someone who's complaining of fatigue or complaining of unfulfilling sleep into a sleep specialist will be very important. I also would do a exercise evaluation in this. And then someone who has a chronic cough, I would do a pulmonary evaluation, looking at the lungs themselves, as well as a GERD evaluation and working up chronic cough as we often do. Next slide. So we're going to jump into some of the testing, and I'm going to focus on just what we found in the radiology. Next slide. So when I classically think of what we have as access to us in a normal clinical setting is chest x-ray, CT scan, and pulmonary function tests in terms of pulmonary. And then cardiac, we're going to touch on EKG, echo, 6-minute walk, and CPET. But I will say that there are a lot of other mechanisms that are being looked at to evaluate long COVID patients in terms of autonomic dysfunction testing or other things that can be done in the lungs, like true dual energy CT scans looking for microclots. So these are I'm just covering the garden variety, what a patient might come to you with already done, not necessarily telling you all the things that could be used to work up long COVID symptoms. Next slide. So I think that a chest x-ray is very much of a helpful screening tool. It can tell you if there is a big thing there, but it never rules out if there's any abnormality within the lung parenchyma. And this is a study that looked at basically time discharge from hospitalization, 3 months and 6 months after patients. And what it shows is that about 50% of patients, even 3 months after their hospitalization, will still have abnormalities that are seen on their chest x-ray. But it is hard to get a lot of information just from this. Next slide. So when we look at CT scans, this is a serial CT scan study that was done over the course of the year, looking at CT scans over 1 year. And they found nearly 50% of patients had abnormalities on CT scans based at a year. Those patients predominantly were ground glass opacities with reticular patterns, and that they were able to find that those radiographic abnormalities actually correlated with PFT abnormalities. Specifically, the reticular patterns would characterize with total lung capacity decrease and residual volume abnormalities. Radiographic abnormalities were more common in patients who were older, had other comorbidities, including smoking, hypertensive, had a lower SpO2, lower oxygen saturation during their clinical evaluations, and also succumbed to a secondary bacterial infection at the time of their hospitalization, acute phase. Next slide. So here are some representative images of patients who have acute COVID over the course of 2 years, actually. D is 2 years out. And so if you look at A, this is the acute hospitalization of COVID, and then B is about 6 months later, 12 months later, and then 2 years later. And you can see that the fibrosis, thickening, honeycombing, and cystic changes kind of evolve over time. And we see some areas of what we call traction bronchiectasis, or dilation of the airway. But the majority of patients did have gradual improvement over these 2 years. 50%, similar to our last study, showed abnormalities at 6 months, and 40% of those patients still had abnormalities at 2 years. The most common abnormality was fibrotic disease, and some patients had non-fibrotic disease. What I will say is early in COVID, we saw a lot of patients come 6 months later with fibrotic disease. Classically, we were taught fibrotic disease does not get better, and we felt like we were going to see a lot of patients that would just become what we call like oxygen dependent over time. But we actually saw some improvement of these fibrotic changes over time. And I think that that is showing us, again, that this is a new field, that we don't know what we don't know to some degree, and that we have hope in that. I cannot successfully prognosticate for all these patients yet, because I do not know what happens in this disease course. Next slide. If we look at pulmonary function tests, we also see a similar story, that pulmonary function tests are worse, persistently worse at 6 months, do tend to improve up to 2 years, but they have protracted abnormalities. I think that PFTs are a very hard test in this patient population, because I think it shows a lot of different abnormalities, and it can be very difficult to make sense of. The one that is very interesting and that does correlate with severity of illness tends to be DLCO, but the restrictive disease of FEV1, VC was definitely significant at 6 months and slowly improved over time. Next page. So this is a meta-analysis looking at DLCO, and I apologize, these are relatively small slides, but you can find this in Respiratory Research in 2020. And what this shows is that the DLCO on average is about 80% still at 1 year for these patients. So a DLCO, the mean was 80%, and that this was relatively found in 30% of the population. The FVC and TLC were slightly lower, only 95%, and only happened about in 10% of the population, so less of the time. Next slide. And I think this is why it is so difficult to correlate PFTs. We talked a little bit earlier in this about how ARDS, or how really bad illness, can impact lung disease. And I think this breaks down PFTs by the severity of COVID illness, mild, moderate, severe, and critical, and hospitalization and non-hospitalized. And you can see if patients required hospitalization, they had a worsening DLCO, worsening FEV1, worsening and worsening ratio in these patients. But it is not to say that people with mild symptoms didn't have these conditions, but only to say that it was variable across the group. So I think that PFTs can tell us a lot of information, but I would say that there's no PFT in my mind that is pathognomonic of someone who has long COVID. Next page. So bringing up COVID and the heart, I think this is a very difficult study, or like a discussion as well. So it was found that SARS-CoV-2 does affect the myocytes in general, and that there can be pericardial inflammation, and that can either progress to edema and then sometimes scar. It can progress to pericardial effusion. It can have these microclots and can cause endothelial damage in these patients, small microvascular heart attacks even, and then can actually cause cardiac fibrosis, and having kind of a change in the cardiac function of the heart in general. Next slide. And so when I think about how to work up these patients, what I would say is, what I hear a lot is that patients are complaining of palpitations. Even in fact, 10% of patients complain of palpitations. But what is remarkable is that some patients complain of this tachycardia that happens when they move from even a sitting or standing position. This is this posterior orthostatic tachycardia syndrome, or POTS disease, which I think is having a large overlap with COVID. Now, I'm not sure of the exact mechanism. I think people are discussing whether they think it's autonomic insufficiency or there's some sort of vascular problem in these patients. I'm not sure if we can say that there will be a single unifying diagnosis. But if someone does come in complaining of POTS disease or a POTS-like syndrome, I do think of long COVID often in these patients. I will say there is evidence of QTC prolongation in these patients that also is related to that fibrosis or the scarring that I was speaking about. Now, we're not talking about cardiac MRI in these patients during this talk, but those would be things that would be working up that condition more. Next slide. Other things, this is just a article that was talking about in Jack that was talking about the ERJ that was talking about different cardiac conditions that happen in patients with COVID. And if you see, there are a lot of things that could be seen on echo. So I think like chest X-ray and like CT scan, it can be a very good screening test, but not one thing makes me think of long COVID in these patients. You could see systolic or diastolic dysfunction, RV dysfunction, thrombus. You could see a myocardial infarction. Somewhat, you can see pulmonary hypertension on echocardiogram. So these are things that on echocardiogram would make me confirm the diagnosis that I was thinking maybe this patient does have long COVID, but definitely not having these conditions does not make me think the patient does not have long COVID. Next page. A cheaper test, an easy test to do is a 6-minute walk. I think this is an important test in all pulmonary clinics, but especially on COVID. It can be used over time to see how a patient's improving. This is just kind of an infographic on how to do a walking test in someone who is on oxygen. I just want to bring up the point that just because someone is on oxygen does not mean they cannot do a 6-minute walk test. And I think it's important to still do those tests on those patients. And I think it's important to also celebrate small wins with your patient in the clinic. So if they do improve on their 6-minute walk test, we can celebrate with them, even if it's 50 more feet. Next slide. A more advanced test that could be done to really figure out the exercise tolerance of a patient could be a CPET, which is a cardiopulmonary exercise test. A cardiopulmonary exercise test basically looks at the ventilation, the cardiac, and the oxygen extraction, and it sees what basically fatigues first in a patient so that you can say that this is the reason why the patient has dyspnea. It sounds like an ideal test in these patients. If I could figure out why the patient has dyspnea, because we have been telling you we don't necessarily know why a patient has dyspnea, I could fix that one etiology. And I think that they can be helpful. But what I want to point out is the slide on the right, or the figure on the right, that shows that there is very little overlap in findings on CPET in patients that have long COVID. We see a lot of exercise intolerance, but we do not see a predominant physiologic problem in them that says, yes, patients are dyspneic because they have mitochondrial poisoning and problems with oxygen extraction, because they have these pulmonary DLCO impairments, which is causing them not to be able to get oxygen out. We don't have one mechanism. So while it might be helpful on a case-by-case basis, it is not going to seal your diagnosis of long COVID. Next slide. So I'm going to just talk a little bit about the studies that are being done, and then I'm going to give it back and talk about what we should do in our clinics. So next slide. So I think what I've said is that pulmonary trajectories do improve for about a year, maybe up to 2. This is in some patients, not all patients. And I think if your patient is not improving, that is not abnormal. And we should validate the fact that they might not. But I do see a pronounced improvement that happens between 6 and 9 months after COVID. that fibrosis is the least likely to improve, but it can, and that's something that we did not think possible, and that traction bronchiectasis does tend to stay. Ground glass persists in COVID patients longer than it does in other syndromes, or longer than we have seen in other syndromes. But in most cases, the ground glass did regress in patients. Next page. So the pulmonary treatments that could be focused on these different modalities that you would have seen continuing in patients are persistent ground glass abnormalities. Now, we spoke a little bit before about organizing pneumonia. This would be on the differential in someone who has persistent ground glass opacities, and these patients could be targeted for steroids or other types of immunosuppression. Antifibrotic agents that we use in our ILD patients, also clinical trials currently underway to see if those can help regress these fibrotic changes. Pulmonary rehab, and I want to put giant asterisks on this because while it can be helpful in some patients, I know that post-exertional malaise is real. And I know that telling someone you need to exercise more is wrong. It's not just deconditioning. It is a lot of things. That being said, pulmonary rehab can be done in a very slow model and can be focused on how to improve patients with post-exertional malaise. And I think this is very, very important in talking to your patients, because if you just tell them you need to do pulmonary rehab, you need to get stronger, that will be a huge turnoff. So I would put giant asterisks next to that. There might be some patients that have persistent viral infections. There are currently studies underway looking at Paxlovid. You have probably heard about metformin possibly being a drug to treat or prevent long COVID, and that it is being investigated. And then microvascular disease. I think this is not necessarily ready for prime time. There are no large clinical trials yet. Again, we need to target the patients that do have persistent coagulopathy. That is not all long COVID patients. And those can be targeted with possible anticoagulation or antiplatelet agents. But again, this is should be done in a research setting. So I will give it back.
Thanks so much, Dr. Brosnahan. I think just underscoring how every patient with long COVID is different, and therefore your exercise advice has to be customized. So this is both of us taking the chance to really emphasize that each patient's sort of exercise prescription has to be quite customized, taking into account whether they have post-exertional malaise or post-exertional symptom exacerbation or not. Johns Hopkins has this really nice free guide called Bouncing Back from COVID-19, Your Guide to Restoring Movement. And they have things like breathing exercises, really gentle exercises to go forth and conquer. The Association of Physical Therapy also says specifically that the traditional model of gradually increasing your exercise is not appropriate in most of our patients with long COVID. And they say that you really have to make very slow progressions or gradations in activity to increase functional capacity. And again, this is a key difference where there's going to be differences with the patients who have that chronic fatigue, myalgic encephalomyelitis overlap, and patients who don't. And so a skilled physical therapist, like ones that work in our clinic, that's one of their first steps, is they try to figure out, are you one of these patients who has post-exertional malaise, post-exertional symptom exacerbation? Then we'll give you a totally different physical therapy pathway than somebody who does it. And the key concept is rest and pacing yourself. So it's very gradual, it's very graded. You have to kind of master your floor. What is the floor level of activity before very gradually moving on to the next? And I talk to patients about, the floor is a concept of what's the minimum thing that you can do that doesn't leave you short of breath, right? For some people, that's walking 7 minutes. For some people, that's walking 2 minutes. And then we talk about how to sort of master that before gradually increasing it, not going from 7 minutes to 20 minutes, but really trying really slow 7 to 8 minutes. People with the chronic fatigue overlap, we often have to do things, like I said, resting, pacing, energy conservation. Those are key principles. It's not the traditional graded exercise therapy advice. And that for a lot of those patients too, we often recommend recumbent exercise to start, so that because those patients often have a lot of those POT symptoms where you get tachycardic. And so a lot of people will start off with protocols like the Levine protocol, among others, where you start with recumbent exercise, just sitting down. First, can you move your legs while sitting down? First, kind of practice sitting up, things like that. There's also kind of websites and breathing exercises program that really try to link the autonomic and respiratory conditioning together, because we know that there's a lot of patients where they have a lot of autonomic issues and that impacts their breathing. So Mount Sinai actually early in the pandemic had created this stasis breathing program for lung health, where they're talking about basically autonomic training, respiratory training, to basically how to retrain your body to have less dyspnea on exertion with controlling your autonomic nervous system. Really intriguing kind of line of thought. A lot of people get better with these principles of autonomic rehab, studied by Dr. David Petrino and others at Mount Sinai. And so this is kind of another area to watch, and there's lots of exercises available online to think about. And the last key point for clinicians to remember is that all that long hauls isn't COVID, and to make sure to avoid anchoring bias and keep your differential broad throughout. For example, I personally in our clinic have diagnosed people who had a label of long COVID by clinicians, and I've diagnosed them with, in some cases, metastatic prostate cancer, metastatic lung cancer, sarcoidosis, hypersensitivity pneumonitis or allergic reaction, postpartum conditions, pregnancy, new pregnancy. There's so many different conditions that all clinicians have to kind of keep a broad mind and make sure that, what else could this be? What else am I missing? And then the detailed workup that Dr. Brosnahan had outlined helps you kind of go through that systematically so you don't miss people. There was just a recent column in Diagnosis by Dr. Lisa Sanders, who runs the Yale Long COVID Clinic, talking about exactly this. She talked about how she had this patient who had long COVID, who was sent to the long COVID clinic at Yale. And that after a while, she actually discovered they had a totally dysregulated thyroid, severe hyperthyroidism that was not identified or treated. And so just keep your mind broad and your mind open to make sure that there aren't other things in addition to long COVID that are affecting the patients that should be treated separately. What other treatments are being studied? As Dr. Brosnahan said, a lot of these treatments are actively being studied right now. This is a great table from the article from Hannah Davis, the long COVID patient and community activist. She wrote this great article in Nature, and that this table is from there. And I want to walk through the treatments. When I think about treatments and patients ask me about different treatments, I often think about treatments where there's a lot of scientific evidence, emerging scientific evidence, things that I'm not sure about, and things that I'm worried might cause harm. And so I think that this table does a good job of kind of walking through those things, because we don't want to do anyone harm. The first things first, what we know works well is this concept of pacing and energy conservation with people with the myalgic encephalomyelitis, chronic fatigue overlap. So there's a lot of literature in the ME/CFS community about pacing, resting, energy conservation, and how gradual exercise doesn't work in that patient population. For POTS, as we talked about, the postural orthostatic tachycardia syndrome, there's both pharmacological measures and non-pharmacological measures. We often start first with the non-pharmacological measures because a lot of people get better with just that alone. And that includes a high salt, high fluid diet, compression stockings, and then again, different exercise modalities like the recumbent exercise, Levine protocol, et cetera. There's also, for some patients with the severe POTS, there's treatments that could be considered like beta blockers, midodrine, fludrocortisone. I caution those that should definitely be done in consultation with ideally a cardiologist, an endocrinologist, things like that, because I've definitely seen situations where people had more side effects from the medication than their long COVID. So you have to kind of really carefully titrate those, make sure that the non-pharm stuff has been tried first. For immune dysfunction, IVIG has been studied in the chronic fatigue literature. There's not much data in the long COVID population, so we don't recommend it as of now. We talked about pacing, definitely helpful. Post-concussion syndrome protocols, definitely helpful. In our clinic, we actually have a cognitive therapist, an occupational therapist, who does a lot of cognitive therapy, occupational therapy, cognitive rehab strategies that really are similar to post-concussion protocols. They find that really helpful. For the chronic fatigue, pain, neurological symptoms, there's a lot of good emerging data from the chronic fatigue community on low-dose naltrexone. There's emerging data on that in patients with long COVID. It seems relatively safe, well-tolerated. So that's something you should consider asking your doctors about. And there's going to be larger trials coming on that. There's some studies showing a benefit of low-dose aripiprazole, which is a specific sort of antidepressant that can help with, fatigue, brain fog, things like that. Again, best to start something like that in conjunction with a neurologist, ideally. And then this last couple of things kind of mirrors Dr. Brosnahan's earlier slides, that these are actively being studied in long COVID. Anticoagulants, Paxlovid, plasmapheresis. I would not recommend taking those outside of a trial because all of these can be high-risk medications. There was even a study on anticoagulation in long COVID where it helped inpatients, but it harmed patients who were in the intensive care unit and patients who are outpatient. So anticoagulation is really complicated, as is antiplatelet. I would not advise taking that in the outside of a trial or close supervision by a hematologist or blood specialist. And then similarly, Paxlovid is being studied as we speak. There's the Stop PASC trial that's going on at Stanford in my area and centers around the country that's going to look for viral persistence. But I wouldn't recommend taking Paxlovid, long-term off-label, because the data are still out there. And that we're still studying that very closely. And stellate ganglion blocks, there's some anecdotal evidence about that, but it's a specialized procedure. Only a couple people can do it. It's very much in the case report stage. And then the antihistamine, there's a lot of overlap with long COVID, chronic fatigue syndrome, the MCAS literature, anti-inflammatory, antihistamine. So again, that's like an area to watch, a space to watch. I think there'll be more evidence on that. And then people who've taken antihistamines often find that for some people, again, there can be significant side effects. For some people, it's pretty harmless. There's no side effects. So again, these are all things to discuss with your clinician before starting on your own. Let's go with our take-home points before we save some time for questions. So I think one of the key things that emerging literature is focusing on is really disentangling the umbrella term of PASC or long COVID, and really thinking about the concept that the RECOVER trial and many other trials and research are focused on, how can we really customize the long COVID treatments and pathophysiology and biology according to you? How can we take this huge umbrella term and really break it up to what are the symptoms people are experiencing? What is the underlying biology? And then what is the treatment? Because a one-size-fits-all approach is probably unlikely, as we've seen patient after patient and huge data set after huge data set show how different this condition is. And so we're trying to kind of separate that out in a way that makes sense for patients and treatment. Dr. Brosnahan shared how the pulmonary and cardiac imaging can be really helpful, but often doesn't tell the whole story. And there is no one pattern that's, quote, diagnostic or, classic for long COVID. But if there are abnormalities seen or other conditions, we can definitely treat those. For example, we talked about pathways of lung fibrosis or obstruction, such as asthma, COPD, arrhythmias, things like that. The current treatments for long COVID, there won't be one that will be right for everyone. We need to work on researching rapidly these new therapies. We need to expedite our clinical trials. We need more funding for long COVID. Myself, Dr. Brosnahan, and many others, and many patient communities are very actively, advocating and lobbying at the local, state, and national levels for more research funding, more clinical trials, because we know that pace is frustratingly slow for patients. And then the last take-home point that we wanted to end on is to listen to everyone in the room, believe patients, and that patients, researchers, and clinicians all need to listen to each other, listen and believe patients, and that we're hopeful that the next time we come back and give this talk, we'll have more exciting new treatments, updates, insights to share. Thank you so much for listening. Thank you for your time. Here's both of our contact information. And so we'll like to pause now for the Q&A. And thanks again for the kind invitation.
Thank you so much. This has been fantastic information. And I know a lot of people are really interested in thinking, wait, what did they say? I need to go back and listen to that. Have no fear. We are recording this. This will be on our website either tomorrow or the next day. You can review it in entirety, and we will also have the slide deck there. So let's go over a few questions. So the first one is, was obesity and comorbidity in patients with OSA that developed long COVID? So was that more of a problem? That could explain the pediatric versus adult incidence.
Yeah, so I think that's a great question. So it was a multivariate analysis that did control for obesity. It still showed that OSA does account for an increased risk of long COVID. There are a lot of mechanisms. Sleep is very restorative to our brain. It gives us time to get out toxins and things like that. And it could be part of the reason why patients are more likely to get kind of brain fog after a COVID diagnosis. But definitely obesity was a component to it, because when those two comorbidities coexisted, there was a higher rate of long COVID.
Okay, thank you. Our next question is, with the sleep evaluation, is it best to go to a facility? They have those little take-home tests in the little pouch you can take home and sleep in your own bed and actually get some sleep. So which do you feel is best?
So they test two different things. I am not a sleep doctor. As a pulmonologist, we do a little bit of sleep training, but I would say that there are more extensive testing that can be done in a sleep lab that can be done from a home test. So it depends on what is right for you based on your symptoms, and you need to talk to a sleep doctor to get the right test for you.
Perfect. And as you've mentioned, there's such a wide variability with people with their symptoms and some other health issues they have. So there's no one size fits all, we know with this. So thank you. Good reminder about that. Another question, and also a thank you. Thank you, doctors, for the very informative presentation. I wonder if it's part of standard care for doctors to ask patients if they've been diagnosed with COVID during an annual checkup. Can patient be tested to see if they have COVID? And they may be referring to maybe checking for antibodies or something with this question.
This is a great question. I think that I would definitely encourage patients to view it as a part of your health history, and that when you see a new clinician, to say, if you had COVID, when was it? What were the symptoms you experienced? What symptoms that you're experiencing now? So I definitely encourage you all to carry that as part of your medical history, because it may be relevant to future things. It may not be relevant to future things, but it never hurts to ask about that and to bring it up. Some health systems, I know ours does at UCSF, they actually have a separate flag on the medical record, including both COVID status as well as vaccination status in a very easily accessible tab on the left. So for me, quickly, whenever I prepare for a patient visit, both in our long COVID clinic, but also in my general pulmonary clinic, I always look at that, to look at what is people's vaccination status and history, what is people's COVID status and history. The antibody testings, it's a great question. A lot of the studies on the antibody testing, which were done earlier in the pandemic, showed that different labs have kind of different assays and that it can be hard to interpret. The best use case right now is often for people with severe immunocompromise, like patients who've had transplants and things like that, to look at antibody levels, to look at their body has kind of a body response to vaccination. And that's where the antibody testing is very well studied and useful. So in general, we are not using the antibody testing for now to see, like, did I have COVID in the past? Did I not? Because we know that the antibody levels can go down over time. They're impacted by vaccination, things like that. So your doctor might order them if you have severe immunocompromise, but generally it's not a test that we say, oh, let's order it for everybody to see if you've had COVID or not. I wish there was a test that said, oh, this person had COVID this many times. We can tell by the antibody testing, but it's just not quite ready for that kind of use as of now.
And we know that COVID is very complex. So as you've mentioned today, so good point on that. Someone says, can fibrosis eventually clear on its own?
So I think, before COVID, before the pandemic, I would have said, I saw a CT with fibrosis. I would say, this is scar. It's never getting better. That being said, I think we've learned that some fibrosis does regress. That does not mean that all fibrosis will regress. And I would say that patients with other types of fibrosis, ILD, not viral related thrombosis, I don't think that has changed my opinion on that.
Whoop, thank you. What was the association of long COVID for all ages or just for adults? And they may have been referring to some that you mentioned a little bit earlier about that. Because we know children can get long COVID as well as adults. So that might have been what their question was. Since 2019, what are the most recent findings regarding long COVID patients who completed COVID vaccine regime and those who did not? And that is always a data question and maybe hard to answer.
That's actually a question where I'm glad you asked, because we actually have a lot of research data on that now. So multiple trials, including this brand new JAMA trial that I mentioned that was earlier this month, show that definitely the amount or incidence of long COVID is significantly less in people who've had vaccinations. And so I always tell folks, it's never too late to get your first vaccine if you haven't gotten one already, to decrease your risk of getting long COVID. That's been proven in multiple different studies, including ones where Omicron was at play, yeah, things like that. And so definitely the vaccinations do seem to be protective. And we see that experientially as clinicians too, that unfortunately my patients who got infected in March 2020, where there was no vaccine available, those are often the ones with the most severe long COVID symptoms, unfortunately, as opposed to our patients who've been affected in the post-vaccine era. So vaccination has been well studied, is safe, can definitely prevent the risk of long COVID in numerous research studies. So definitely get one if you haven't already.
Makes sense. Makes sense. We need that protection, any protection that we can. Is there evidence to promote, and you talked about this already a little bit, to promote exercise, pulmonary rehab, post-COVID to improve long COVID outcomes? Should we be encouraging patients with long COVID to exercise as tolerated to improve recovery outcomes? I know this is going to be really hard for those type A personalities that want to jump back into their regular life, and that's just not going to happen. So I need, and that's maybe something, sorry, that you could talk about. You talked about just going slowly, like going from 7 minutes to 8 minutes and that type of thing. And even if they can just do.
Yeah, so I think, it's a great question. I think it is not one size fits all. I think this needs to be done in the, some patients can rehab after an acute illness, but I don't think long COVID is something that can necessarily always be done independently. And I think we need to talk with our patients and really tell them we're doing this as a structured approach so that we can make sure we're giving you an individualized care plan on how to get stronger. And that will be different, I think, depending on patient symptomatology, post-exertional malaise, depends on how fast we can go with some patients in rehab. And I think that our PM&R colleagues are amazing, and I appreciate them every day.
Thank you. And I think that's one of those really underutilized options that people have for that. And some people haven't even heard of it. So let's see what else we have. People were talking about, when you talk about ground glass appearance, is this the same that is found in sarcoidosis?
Sarcoidosis is one of those diseases that can do a million things. It can do anything, actually. In general, sarcoidosis isn't found with tons of ground glass opacities. One of the conditions that these ground glass opacities can be similar to or can be related to is what we call organizing pneumonia. And that's basically what we think happens, although we're not exactly sure, is that we kind of get an autoimmune-like reaction in that area where there's persistent inflammation. That's why we target immunomodulating agents like steroids or other agents that in patients who have organizing pneumonia. We're not sure exactly why patients with long COVID, some of them have GGOs or these ground glass opacities, but we're hoping to figure out the phenotype, looking at different labs in them and figuring out if they do have an autoimmune process that's underlying it.
Thank you. And I'm sorry, we're going a little bit over time. We have about 4 more questions. Are you both okay to stay on the line? Okay. Have you seen an increase in atypical strep after COVID, such as group G pharyngitis?
I can't answer the question about strep directly, but we have seen evidence of more atypical infections in general. There have been more fungal elements seen in bloods. There's been more fungal elements seen in the lung. So I do think this is part of the areas of research that's looking at our microbiome, both in our lung and our gut. That will be interesting to see what happens after COVID. And I think it's a big question, because I think we also did a lot to just viral and infection kind of in the whole world by shutting down for a while. So who's to say what the exact reason is, but I will say that it does appear that there are different infections that are happening. I'm not sure if we can say it's exactly because of COVID, global warming, shutting down, who knows, but things are different.
Yeah, throw all those factors in there in this crazy world, right? Someone asked, oh, this is a big question. Whoever wants to answer this, do you have any idea how many patients have had to receive transplants due to COVID? And I don't know if they're referring to lung transplants or something else, but. feel free,
Yeah.
whoever wants to answer that.
It's a great question. I would say that one of those things where people who have really severe COVID, landing them in the ICU, where they have this fibrosis that doesn't go away, they're at that stubborn plateau where they didn't recover. And often people have had other lung conditions before that, and then they got kind of tipped over and now they've never recovered. That's kind of the candidate that we think about getting a lung transplant. Lung transplant is so challenging because you have to be kind of quite sick to get a lung transplant, but not too sick and not have any other problems in any other parts of the body to get a lung transplant. And so it's a very select patient population that's eligible to get a lung transplant for COVID. And often it's that very seriously ill population. The short answer is that lung transplants worldwide have increased with the COVID pandemic. And one of the most common causes worldwide of getting a lung transplant in the COVID era is infection, severe respiratory failure due to COVID. So definitely transplant volume has gone up nationally and globally, and a huge part of those have been related to COVID. But again, that is often for that subset of people, it's very severe respiratory failure who never quite recovered.
Wow. So more lung transplants on top of our already overworked and burned out medical staff. Yeah, it sounds like. Someone else asked, are women more likely to get long COVID?
I think prevalence is still something we're having some trouble necessarily estimating, because I see that there was another question about prevalence, but I will direct everyone back to that JAMA article again of the Recover Initiative that is at least hypothesis generating at this point. And it does show that there's a predilection for women to have long COVID over men.
Okay, just along with all the other fun things, right? Hot flashes and all those other fun things women get to deal with. So we could be here all day. We've got a few more questions. I apologize to everyone. We can't get to them all. As a reminder, this is being recorded and will be uploaded on our website. Please join us for our next webinar. Was actually tomorrow. We're doing 2 back-to-back webinars. Tomorrow is knowing the difference between asthma and COPD. So thank you everyone again for joining us. This is Andrea Jensen for the staff at Allergy and Asthma Network. Join us as we work every day to help everyone breathe better together. Thank you again, both. You're fantastic and brilliant. Thank you.